Hello everyone, I'm Dr. Prashant, and in this presentation we will talk about the clinical features, diagnosis and management of dengue fever. Let us begin with a brief description of the structure of the dengue virus. This is the overall structure. This is the capsid, this is the nucleocapsid, this here is the viral RNA, and these are the E and M proteins. When the dengue virus invades the body, it invades the monocyte and macrophages. At this time, there is release of pro-inflammatory cytokines which are responsible for most of the clinical features of dengue fever. This so-called cytokine storm alters the vascular permeability in the blood vessels of the infected host. This results in clinical fluid accumulation, which is responsible for the symptoms such as pedal edema, pleural effusion, and ascites in dengue. The spectrum of illness in dengue may range from an asymptomatic infection, which is also called the subclinical form, and this infection is self-limiting and there are no symptoms or sequelae. However, there can also be an immunopathologic response, in which case there are clinical features of varying severity. The clinical features of dengue are fever, malaise, pharyngeal involvement. There could be myalgia. There could be break bone symptoms, and this generally indicates the bone marrow is involved. There could be headache, retroorbital pain, along with prostration, backache, and musculoskeletal pain. Patients with dengue fever also have a rash, and this is initially manifested by flushing of the skin, followed by macular rash with sparing of the palms and soles. The rash eventually fades and desquamates. However, localized clusters of petechiae may remain. The bleeding manifestations in dengue include patients with pre-existing peptic ulcer could have a life-threatening bleed. There could be subcapsular splenic bleed or rupture. Splenic rupture is also a feature of infectious mononucleosis. There could be gynecological symptoms such as metrorrhagia, spontaneous abortion, and postpartum bleeding, and there could be bleeding diathesis, which is unrelated to the dengue infection and may be related to the shock and hypotension of dengue hemorrhagic fever. The clinical phases of dengue fever include a febrile phase, which generally lasts 4 days and is accompanied by fever, chills, and other symptoms as described. Next is the critical phase, which lasts another 4 days and is characterized by thrombocytopenia. However, the patient experiences defervescence during the critical phase, in that the fever generally subsides. Finally, the patient could have a recovery phase in which the fever and the symptoms, including clinical signs such as those of fluid accumulation as well as lab signs such as those of thrombocytopenia, subside. However, recovery phase may often be complicated by overjudicious use of IV fluids. Dengue severity is described based on warning signs. Therefore, dengue may either be with or without warning signs, or there could be severe dengue. The warning signs of dengue fever include persistent abdominal pain or vomiting, clinical fluid accumulation, and this is responsible for pedal edema, pleural effusion, and ascites. There could be mucosal bleed, epistaxis, gingival bleed, hematemesis or hemoptysis, and a liver palpable more than 2 cm below right costal margin, and a rising hematocrit or a falling platelet count form the warning signs of dengue. Severe dengue is said to be present when there is severe plasma leakage causing shock due to fall in arterial pressure. Severe dengue may also be present when there are hemorrhagic manifestations resulting in a clinically significant bleed. Or there could be evidence of organ dysfunction. This is the portal vein, this is the splenic vein, this is the superior mesenteric vein. The green colored structure is of course the liver, this is the gallbladder. In a patient with severe dengue, there could be evidence of organ dysfunction in the form that there could be a rise in transaminases of more than 1,000. The diagnosis of dengue is based on NS1 antigen detection, and this is the most common form of diagnosis of dengue. There are also other ways, such as a serology, in which we use IgG or IgM to diagnose the condition. There could be genome detection or viral isolation. The latter two are rarely done and rarely have any utility in contemporary clinical practice. Monitoring of a patient with dengue is done using their pulse, blood pressure, skin perfusion, and hematocrit. All this is to be done while the patient is under an infusion of normal saline. Treatment of dengue generally involves monitoring of the patient as described, including their daily platelet count and hematocrit, monitoring for warning signs and for signs of shock. In patients who have signs of compensated shock, in that the systolic pressure is maintained but has evidence of organ hypoperfusion, we must administer crystalloids at 5 milliliters per kg per hour for 1 hour, followed by reassessment for improvement. If there is improvement, then we can give IV crystalloids, and this generally includes normal saline at 5 to 7 milliliters per kg per hour, followed by reducing to 3 to 5 ml per kg per hour for 2 to 4 hours, followed by a further reduction to 2 to 3 ml per kg per hour for the next 2 to 4 hours. This is followed by reassessing the hematocrit. In patients who don't improve after an initial fluid bolus of 5 to 7 ml per kg per hour, we must check the hematocrit immediately. If the hematocrit is high, we must administer 10 to 20 milliliters per kg per hour of crystalloids for 1 hour, followed by reduction to 7 ml per kg per hour and reassess the patient. If the hematocrit is low, we must consider an overt bleed and consider whole blood transfusion. That's it for our presentation on the clinical features and management of dengue. Thanks for watching, and we will see you in the next video.